Okay, so it's time to start. Thank you, everyone. Thank you for joining us in the third session of the Transparency series that Salud por Derecho has been organizing this year. As you may know, the first one we dealt with advances in Spanish legislation. The second one, we went through civil society actions to improve transparency in Spain, South Africa, and Colombia. And today we are diving into what's worked and what hasn't in medicine transparency initiatives across regions. So in these third episodes, we're going to explore lessons for both Europe and Africa from the European Union and Uganda on how to make medicine pricing systems more transparent and accountable. We'll take a look first at the EU Transparency Directive, and then we will go to learn more about the work of Meta in Uganda, as well as regional African approaches. First, Dr. Rianne van den Ham is going to start with her presentation. Rianne is a trained pharmacist and epidemiologist and holds a PhD in pharmacoepidemiology. And she's currently working as an assistant professor in the field of access to medicines at Utrecht University and as managing director of the Utrecht WHO Collaborating Center for Pharmaceutical Policy and Regulation. And her research and teaching are driven by strong motivation to improve access to affordable, safe, and effective medicines worldwide. So over to you, Rianne. And if you guys have any questions, please write them in the Q&A, and I will be collecting them for later on. Thank you.
Thank you so much for the introduction, and I hope that my slides are visible. So first of all, thank you for the invitation. Very nice to be able to tell you something about the work that we did. And it's important to note that we as Utrecht University, together with my colleague Aukje Mantel-Theeuwissen, were part of a bigger consortium called the EU Health Support Consortium, led by NIVEL, which is the Netherlands Institute for Health Services and Research, and together also with colleagues from the National Institute for Public Health and the Environment, Health Connect Partners, and RCSI. We conducted this study on looking at the functioning and the implementation of the Transparency Directive. So this is the group that we worked with. And the aim of this study was actually to gain insights into how the Transparency Directive, quite an old directive, was actually functioning in the landscape as it is today. So here are some other objectives that we had. So it should be a factual analysis of the implementation. Also see what are actually the benefits and challenges faced by all the stakeholders in its functionings, and also see what are actually the opportunities of this Transparency Directive to better apply to the current situation. It was important to note that it was not meant as a formal check or compliance on this Transparency Directive. And we really wanted to focus on the transparency of pricing and reimbursement procedures and not so much on medicines prices, because this needed to be clear before we started with the project. So, as you may know, the Transparency Directive actually was applied in 1988 and incorporated into the law in 1989. And here I list the different key objectives of this transparency. And it actually originated from the aim of the EU to try to create a single internal market. So products, including medicines, would be able to move freely across borders. But it was for medicines especially complicated because each country has its own rules for how medicines were priced, how they were, through which criteria they were reimbursed, for example, and also how long decisions took to be taken by the different countries. So this in the end also led to delays in access to medicines in some countries, and it was also not clear to manufacturers to which criteria criteria they needed to adhere in which country. So the overall aim of the Transparency Directive is to harmonize some basic rules, but also take into consideration that national control over pricing and reimbursement should not be impacted too much. So that is a careful balancing act there. In the end, I put the objective here. It was to increase transparency of measures that regulate the pricing and reimbursement of medicinal products for human use. And then I'm not a lawyer, that is maybe good to note, but of course, within the directive, there are some key provisions, and this table, it also lists the requirements that come to it. So there are some key provisions that detail some requirements about the pricing, so price decisions, but also price freezes and profit control. And on the other hand, also some articles and key provision that regulate the reimbursement decisions, and in the end also some Commission and Council actions. And the most important requirements are that this Transparency Directive actually set certain time limits between the date of the complete application being submitted by the manufacturer and the decision of the authority. And for that, 90 days are given for the price setting and 90 days are given for the reimbursement decision. So in total, the whole process can take 180 days. Also, the criteria should be clear, objective, and verifiable, and also communicated upfront so that there's better predictability for companies that submit a dossier. And decisions should be justificated, and also this should be published and findable, available to the public, so that they are aware of the decisions and why these decisions are being taken. And of course, there should be a right to appeal to this decision. So these are the main important things that are regulated by this directive. So we did a study that consisted of several components, a literature scan, also mapping the important stakeholders, so which institutes were very relevant and to which institute were actually was this Transparency Directive applicable to. Then we used so-called country fiches from the member states, and these country fiches were produced to collect all the relevant information about the pricing and reimbursement processes in these countries. We actually asked targeted persons that were working at the national authorities to fill this in, and also we tried to fill in some gaps by looking for information ourselves. We organized 2 different workshops, one with all the stakeholders and others with another one with member states, and there we gathered some information about the experiences and also the views of the different stakeholders with respect to the Transparency Directive. And finally, we also had a public consultation. Maybe you've also seen that because it was open to everyone to fill in, and this all contributed to the results in the end. Yeah, this is some details about what kind of things we collected in the country fiches. So it's also interesting to note that in 2011, there was already a public consultation. And there were also already some interesting results coming from that. So most stakeholders saw that there was a positive impact on transparency and PNR procedures. It could have a positive impact on the speed of these PNR decisions. But also they saw that there was room for improvement because maybe there was some incorrect application of the directive, and also because the pharmaceutical market became more and more complex, that this directive was actually not fit for purpose anymore. So it actually led to a proposed revision, but it was withdrawn in 2015. So now I will go over to the results, and I will cover 3 different themes. The first theme being the implementation of the Transparency Directive. And for that, I used the information from the country fiches that member states filled in. And what we saw is that, as you may know, that pricing procedures and reimbursement decisions are taken through different processes. So there are quite variant between member states. There are also different ways of reporting. You can see that in the table. So some countries use legal journals, for example, for reporting of decisions and prices. Others use websites of the competent authority or the Ministry of Health, but others also use other sources. So that also makes it difficult to trace where all of these decisions or criteria are being published. Another way of reporting data were through the Europid database. Maybe you've heard of this, but this is a database which is not open to the public, but it can be accessed by the national competent authorities and the members of the PPRI network. So this is to show how member states view the occurrence or how often certain situations occur. On the left-hand side, some occurrences on price decisions, and on the right-hand side on reimbursement decisions. You see that a number of countries actually say that the percentage of cases where the decision of the price is taken within 90 days is done in 2/3 of the cases. So that's quite positive. When it comes to reimbursement, that is more or less similar, but maybe a bit more variant over the different cases. There are some instances where member states or companies make use of the stop the clock procedure. So this means that the applicant is asked to deliver more information. So then the time limit stops. And then most countries in the end, or member states, take a decision after the continuation of that timeline. Although one country says that it's not able in 100% of cases to make the decision within the given time period. Oh, sorry. It's important to know that we are not aware of the exact reason why it was not possible to come to a decision within the timeline. It may be because there's a lack of information and this is not actually breaching the timeline. So that is important to note. Then some experiences that we noted down about the functioning of the Transparency Directive. And then we asked the public if they have experiences with the functioning of the directive. And I must say that the people that responded to this survey were aware of the Transparency Directive. I think many people that are active in the pharmaceutical landscape maybe do not know of the existence of this directive, but these people were aware of it. They generally think that the pricing procedures are clearly defined, but it is difficult to find the information. Half of the people said that. And also the information on the timelines is not easy to find in the countries, and also the information on the remedies. So on the one hand, they say it is clear which kind of procedures are used, but finding the results of these procedures is difficult. And then when it comes to the reimbursement procedures, I think the key finding here is that most of the respondents agree with the fact that the information on the list of products reimbursed can be easily found. 62% agrees with it. But for the other items, namely the reimbursement procedures, information on products excluded from coverage, and information on remedies against reimbursement decisions, I think they are quite balanced or somewhat opposed. And then the functioning of the directive specifically. They say there were different levels in increasing transparency of measures, that decisions are based on objective and verifiable criteria, and if they help the functioning of the internal market. There was quite a large variety of the responses of the public here. And it's interesting to see that the majority of respondents disagrees with all of these aspects. Yeah. So then some narrative feedback that we got from the stakeholders, but also from the member states. It's important to note that the stakeholders were mainly industry and representatives and wholesalers. They had difficulties with finding information. They say that the timelines were not always met in the directive. They also mentioned that there was a lack of transparency on the R&D costs of pharmaceutical products. Probably this is not something that was mentioned by industry representatives, but it was mentioned at least one time. And is also not covered by the Transparency Directive, maybe important to note as well. They also say that the confidential price agreements coming, for example, from the managed entry agreements are not part of the Transparency Directive. And it also needs to be more clear actually what the scope of the directive is. It was apparently not clear if the directive would actually also include generic medicines, and it does, but apparently stakeholders are not clearly aligned on that. Then member states indicated that they find it very challenging to meet timelines. And sometimes these timelines are not met because the procedure is stopped and there is a lack of adequate information. MS also of member states also indicated that they would appreciate a more differentiated approach. For example, it's much more easy to decide on a generic product than gene therapy, for example. So it also depends on the complexity of the treatment and the level of uncertainty that there is in the data that support the application. And also they struggle with the fact that it's difficult to see what kind of prices need to be shared. In the public domain, you often see list prices, while for purposes of external reference pricing, it is important to know something about the net prices, and that is not accessible to member states. So things are comparable between stakeholders and member states, I would say. They both comment on timelines. They both comment on the clarity of the procedures. And then the final theme, and I hope that I'm still a bit in time, is that they generally indicate that the directive dates from 1989. There were a lot of changes, both in the type of products being developed nowadays, but also the change of the legislative environment, and therefore it's not well aligned with the current changes. The stakeholders mentioned that these new concepts are actually not covered by the Transparency Directive, that there's a rising uptake of generic products, and also they mentioned specifically the new HTA regulation that started in January 2025. In this, there will be joint clinical assessments by member states. And this may also impact, of course, timings and the timings of decisions. So this should be taken into account. Member states also mentioned the confidentiality of managed entry agreements and the alignment with regulations. And they also need more guidance from the European Commission on what should be actually published and should be publicly available. So what are potential actions according to the people that we have included in our study. They need better guidance on the requirements, scope, and reporting criteria. This can be done, for example, by practical tools such as workshop. Another idea that came up was to have a more harmonized reporting system, such as a dashboard, or maybe expanding. There is already some kind of dashboard not open for the public, Europit, but maybe this can be expanded. And also see what the HTA requirements are and if this actually aligns with the directive. Then the stakeholders had similar wishes, and also it's important to note that again member states say that there should be maybe diversity in timelines depending on the complexity of products. So conclusion, that directive is seen as useful, and that it may be updated, of course, on the current landscape. We saw that the information on pricing and reimbursement procedures vary a lot. There is a variety and diversity of opinions among stakeholders. For example, regarding the timelines and how that is being perceived. Both stakeholders and member states need technical guidance and tools to make the directive as implemented as effective as possible. But member states still highlight the practical challenges that they have. It needs a continuous assessment and try to the directive should still serve its intended purposes. We also have in our report, and I think that will be shared with you as well, a number of actions that could help to support this currently existing directive. And if you have any questions, feel free to reach out to me. I'm happy to answer them. Thank you. Oh.
Thanks a lot, Rian, and thanks a lot for sticking to the time. A number of things presented that are very interesting, and I encourage the public to think of it for the next Q&A session. There has been a number of challenges that have been mentioned, and they are related to how confidential agreements are rendering the directive not as useful as it was conceived at the beginning. So how do we move forward in facing this new reality, but also how the timing of the decisions might be impacted not only by capacity or the lack of capacity of the regulator. And I was wondering how also the pharmaceutical companies' negotiation strategies can affect these times that has been reported largely on the prices they request, but also the fact that the member states are requesting clear specification on price types. I think it opens a lot of space also on the way to move forward and how to open databases such as Euripid to the public, but I will also include to the global payers. So I leave these questions in the air for the attendees to reflect upon and discuss after Denis' presentation, which comes next. So a bit of an introduction for Dr. Denis Kibira, which is a pharmaceutical policy analyst and health system researcher with over 20 years of experience. He's a qualified pharmacist holding a PhD from Utrecht University, and he's currently the head of DUMIC Global Health in Uganda and coordinates the Medicine Transparency Alliance. In that country too. He's a leader in policy development, access to medicine advocacy, and strategy development, and his expertise spans from strengthening pharmaceutical supply chains to formulating health policies, including to the contribution of the WHO Global Advisory Groups for guideline development. So Denis, Dr. Denis, over to you. Thanks. Your mic is muted.
Sorry about that. Let me share again.
Yeah, please go ahead.
Are you able to see my screen?
Not yet, but it's loading.
So, Jobe, thank you so much for inviting me to speak to this gathering of transparency enthusiasts, and I'm happy to share my experience from Meta Uganda. Please confirm if you're able to see my screen now.
Not yet. Give it a couple of seconds. Now it's sharing.
Okay, because that first picture there is really important to what I'm discussing. And this picture is taken from Eastern Uganda, probably. And as you can see, in the middle is a pot of local brew. And in the picture, you can see women, you can see men, you can see older people, you can see younger ones. There's also rich and poor. And this is something that happens in the late afternoons and evenings in Uganda, where communities come together to sit together and take a drink. And what you can see from the picture is that you must trust the people that you're sitting with in order to share the straws. You can see other people are waiting for the straws. But also there's information sharing. There's a lot that happens. And for me, that depicts transparency and accountability, because a lot of trust is required in this. I'll share a little bit about Meta Uganda, but first I'll talk about my organization. At Do Make Global Health, we strengthen health systems through research, capacity building, but also policy engagements. And we are the hosts of the Medicines Transparency Alliance, which is a platform that brings together civil society to dialogue with the public sector, the government, and the private sector to improve access to health commodities in the country. And the cheetah symbolizes what we are and what we do, because Duma is taken from a cheetah. Duma is a cheetah in Swahili, and it's an African native animal, and although small, it's very powerful and agile, and that's what we symbolize. And just a little bit of background before I go on is that, you know, whereas Africa bears the brunt of disease burden globally, the health expenditure is just a small fraction of what is spent on globally. Pharmaceutical manufacturing in Africa contributes to just 30% of global production, but only 0.1% of vaccines in a place that actually takes up 25% of the global vaccine demand. And so most of our pharmaceuticals are imported. Unfortunately, our governments have also not put in enough funding for health. Health insurance coverage is really low. A recent study in 2021 showed that it was below 8% in sub-Saharan Africa, but much lower in many, many other countries. It's a few countries like Rwanda that have tried to reach 80%, but other countries are really low. And so out-of-pocket expenditures on healthcare are really high. As you can see, many times we have been going to ask for aid because we are not able to meet the demands of our population. And with those limited resources, certainly transparency and accountability is important to ensure that whatever little is there is used optimally. At the start of the Millennium Development Goals era, when countries came together to try and do something to improve healthcare, particularly in low and middle income countries. And this marked a crucial era in terms of improving health outcomes, financing for health, and the World Health Assembly resolution of 2001, where member states agreed to development of systems for voluntary monitoring of medicine prices, but also reporting of global prices, was really crucial for us who work in this area. It led to the development of the WHO Health Action International Medicine Price and Availability Project. And as of now, surveys have been done in more than 50 countries, although that's about a quarter of the countries in the world. It's still a bit substantial. There were also survey tools, resources, and a database was created for that. But also the WHO developed a guideline for pharmaceutical pricing policies. So as you can see, the reports below there, they show that the first pharmaceutical baseline study was done after that under this WHO high project in 2002 in Kenya, both Kenya and Uganda, but also in about the same year in Ghana. And Uganda continued to monitor prices, availability, but also price components, and that is the add-ons of medicines across the pharmaceutical value chain in the country up to about 2015, 2018. And with this also, the Medicines Transparency Alliance was born in 2008. And this was an initiative of the British Department for International Development, which is now the FCDO, which picked lessons from the extractives industry, where different stakeholders would come together, and that participation improved disclosure, and that disclosure improved transparency. So, and it was thought that if that was applied to the medicines market, that would really help. And it was initiated in 7 countries. 3 of those were in Africa. It has gone on to roll into other countries like Kenya. There's bits of it in Burundi and Rwanda. But again, the principles of this were that the countries had to sign on to this, and that the ministries of health had to steward the process and to come up with a research agenda, but also to ensure that civil society organizations that were involved were capacitated to be able to sit on the same platform with the other stakeholders to have a conversation of peers. A pilot was first conducted in 2008 to 10 with an international secretariat in London. In phase 2, the DFID funding secretariat was with the WHO and Health Action International, but that ended in 2015 when the DFID funding stopped, and then it was up to country-led efforts. And Health Action International continues to support many of these few projects that are still ongoing. And the strategy is that tools are provided for the measurement of a basket of commodities, and capacity is built, civil society and other players in conducting these studies, but also in moving the studies to policy advocacy. And then with the research that is done, the multi-stakeholders platform comes together to discuss a way forward to influence policy. So that's the strategy with which Meta has operated in the countries where we've worked. And the scope of work has been with regulation, working with the national regulatory agencies, ensuring compliance, but also implementation of policies, monitoring, being the ears on the ground by communities to report, and then sharing this information, which is then supposed to be used for stewardship of the sector. Some of the successes in Uganda, we've trained over 75 civil society organizations, and many of these have gone on to have desks on access to medicines. A number of advocacy campaigns have taken place and social accountability initiatives within community. One of the campaigns that are still dear to my heart is the Stop Stockouts campaign about 2009 to 11, which led to a lot of policy changes in the medicine sector in Uganda. The budget for medicines was doubled. The president created a monitoring unit to ensure there were no stockouts. There were a number of considerations also made to change the supply chain and its financing, and that was really crucial in terms of creating a background of where the country has come this far. But also civil society, it's the first, through Meta, that was the first engagement private sector and civil society had to dialogue with policy makers on access to essential medicines. And they've gone on to get involved in policy formulation under the different technical working groups of the ministries. When I was at HEPS Uganda, we actually spearheaded the development of the National Medicines Policy and two national pharmaceutical sector strategic plans. Also engaged in health system strengthening work, training health workers on pharmacovigilance, but also setting up reporting system with the Drug Regulatory Agency to report on adverse drug reactions. It helped with improvement in data disclosure. These surveys were online, but they were also used to inform policy changes. Worked on a drug register of the National Drug Authority, but also helped put innovations, for example, getting consumers closer to the regulators through them sending an SMS to verify registration status of either a medicine or medicine outlet or even a manufacturer. And some examples, as you can see here in the monitoring, that these surveys were used to actually be able to validate routine data that the ministries of health in the different countries, as mentioned there, have done, but also to check the pricing in the private sector. As you can see on the far right is the add-ons for unimported artemether lumefantrine in the rural areas, and the add-ons are up to 450%, with the retail taking up 150% of the manufacturer's price of medicine. And so these studies were really important, but also on the demand side, using the same information to come up with patient initiatives, for example, coming up with average prices for commodities, and then using that to have flyers and information into the public that what price they expect to buy a particular medicine, and so they shouldn't be cheated or shouldn't pay more unless they are able to pay more. Having social accountability meetings in community, but also working with radio to get community voices on various aspects of medicines. As you can see on the lower side, the far right lower side, that's a poll asking community members on where they normally get medicines when they get sick. That's also to understand health-seeking behavior. And so if you can see from that graph that the male would usually go to the private health facility, and the females would go to the government facilities mostly. So that again helps to be able to inform policy decisions. Some of the lessons and challenges and opportunities in this work, what we saw is that the meta secretariats that lasted were actually under civil society offices, where offices were under government. Those ones closed really quickly, but with civil society organizations were able to continue and raise funding for this work. But one challenge that continues to remain is the political will at country level across many of these countries. Many countries have transparency legislation, their ombudsmen, government ombudsmen to check corruption, but little is done to ensure that information is out in the public. But also lack of funding. As we speak now, Meta has not been funded in many of these countries, and most of these Meta offices have closed. We relied a lot on donor funding, but with the changing donor priorities, we see that funding has really stopped. I think the philanthropists like the Soros Foundation that used to fund most of this work have since changed. But also governments, as you will see this year, most governments are moving right, and issues like transparency and accountability are one of the least concerns that many governments have. But also a number of global initiatives have either not taken place. There seems to be reluctance by the global community to push for transparency. One of the most important tools that we used to use as researchers was the price reference catalog by Management Sciences for Health that would help to see, to check reference buying prices and selling prices at the global level. But this has not been updated since 2015 and is more or less obsolete. The WHO, the World Health Assembly resolution in 2019 on transparency of the medicines market was also really important, coming close to 20 years after the resolutions on global price disclosure, but also monitoring. But not a lot. This has remained loose. It's not binding to countries, and not a lot has been done in this area. And yet procurement remains one of the biggest abused areas in the health sector. That's where corruption happens most, but civil society is never open to that information. But also non-disclosure agreements in bilateral agreements and in government procurements are really a big hindrance. If you remember during COVID-19, many poor countries, even Uganda inclusive, were buying our COVID vaccines 2.5 times more expensive than what the European Union was paying. And this is insane that, the poor are made to pay much more. In South Africa, an NGO public citizen had to take the government to court to compel them to release the prices that they were buying from these pharmaceutical companies. And the prices were really obscene. They were much higher than what was paid for in other countries. And so certainly these are big challenges in transparency and accountability impacting on access to medicines. But again, there are opportunities we need to be optimistic. Meta and such initiatives are still the only multi-sector and multi-stakeholder initiatives widely relevant, and especially as Africa seeks self-reliance, this will come out handy in these discussions. Secondly, many countries have legislations on transparency and accountability. The implementation is another thing, but at least the legislation is there. But also as governments, as donor support reduces, now governments have come to realization that they have to put more money in health. And as they do that, the governments should put money into accountability efforts. And I think the next frontiers for us will have to be stronger collaborations between civil society with the private sector, but also academia. And I'm really happy to see that my university, Utrecht, is involved in this discussion. But also, we need more initiatives to monitor, but also the implementation of transparency initiatives like the WHO resolution. African Union has also made some steps. There are a number of initiatives that have happened, and these countries really need to take these on and domesticate them. The African Union Development Agency's pharmaceutical manufacturing plan for Africa is one that needs to be countries that need to take on, but also Africa CDC's platform for harmonized African health products manufacturing, and the African pool procurement mechanisms. Hope these can help, pool demand, but also be able to share information on production costs, on buying costs, on epidemiological trends that are needed not only by manufacturers but also by policymakers. The African continental free trade area would also be very crucial in terms of breaking down the barriers that we have. It's very absurd to know that it costs me less to travel from Uganda to Europe than it is for me to travel to, say, Democratic Republic of Congo, even Ethiopia, which are really countries within the region. But also moving imported goods from India to Uganda, it's much cheaper to move the goods to the Kenyan border, but moving those goods by road to Uganda could be double the cost. And so this trade initiative that is being done should look into solving these infrastructural and logistical challenges that we face, but also these non-tariff barriers like costs of visas and other issues, which still hinder access to medicines on the continent. So yes, that's it. I want to acknowledge this information has been gotten from documents that have been prepared over the years from different partners, HI, HEPS Uganda, the Medicines Transparency Alliance in the different countries, but also has been reviewed by my team at DoMake and different WHO and HI and Ministry of Health projects. So I thank you and welcome your questions.
Thanks a lot, Dennis. Thanks to you both, Dennis and Rian. We now open the floor for discussion. Important topics have been raised also in this last presentation on both the role of civil society in ensuring transparency again, but also how the price disaggregation at landing page can be also extremely necessary for improving access, and also what's the room for transparency within the current political climate. So please raise your hand and we will open your mic for questions. Okay, so while people warms up for a question in this last 10 minutes, I have one question first for Rian, and it's there was a number of things that were mentioned by the stakeholders in your study that at the end are discussing about topics such as information asymmetries, accountability, and how to ensure fair prices. So if you were to pick as an expert the top priority actions for reviewing the Transparency Directive, what do you think we will need to focus more on? Is it, for instance, to discuss the role of disclosing confidential discounts? Is it about expanding access to unified databases, or are there any other systemic change that the European Transparency Directive can envision?
Well, a very good question. And of course, I thought about this a lot. And I wouldn't know what actually to change on the Transparency Directive, but I really see a benefit of sharing information between member states, for example, because I do see that the key for moving this forward, I think, is collaboration between member states, because if there's only one country changing something in their processes or procedures, that will not have a big effect, and maybe even have the consequence that they will suffer from those changes. So I really believe in collaboration, and I also strongly see the benefit of exploring a better use or a more broader use of Euribit, or a similar dashboard that could help not only national competent authorities to share information, but also sharing information to the public in a more harmonized way. Because I also feel that patients have the right to know what kind of medicines can I access in my country, how are they priced, how is the price built up, for example. So those kind of things, I think, could be maybe visualized in a dashboard and also harmonized between the different member states in the region. So I think that would be my focus.
Thanks a lot, and that's very interesting. And one of the next sessions we will be holding here is to discuss about a pilot project that was proposed by OCDE on how to build such platforms, but at a global scale. So imagining a Euribit that is accessible for states not only within the EU, but more broadly, and why not to the general public? Some things will remain, I guess, still an issue, such as confidential discounts, but we have experiences also in the Euribit database with countries such as Austria, but I know Australia does it also at their level, where when they cannot disclose the net price, they flag that there is a managed entry agreement or some sort of confidential agreement that it's making the price not as reliable as it was a net price. So then authorities in other countries can calculate what could be the discount that according to literature. So
indeed, for example, the Netherlands also reports their collective rebates that they got over the year. So it is not, you cannot trace it back to specific products, but at least you know that the Dutch government in general gets a 20% discount on products in total. So it will give you some kind of impression what could be the discounted price in the end. So then it's important indeed to know, was there a managed entry agreement or some kind of confidential price indeed? Because I know that countries really need references. So I think that was also touched upon by Dennis. There once was this MSH a reference pricing guide that countries could use as a global reference, but that is not in use anymore. So we need to find other ways that countries are supported in their decision making and can look at others. So a collaborative effort, I think, is very important.
thanks a lot, Rian. And there is a question on the Q&A that's intended for Dennis. How did you secure government buy-in that you mentioned the HMU by the president? Additionally, did you engage the private retail pharmacies, since this is where most patients get their medicines? And I drop you another one on top of this, because you mentioned, and this is very relevant, that procurement remains a gray area in health systems. And we have shown the graphic where retail markup was the largest price of how the price is composed for the user. So how do we fight for this kind of transparency when some of us are focused as state level negotiated price, but then we're seeing the landed price change dramatically due to wholesale margins?
yes, how do we get the president to react and set up the health unit, monitoring unit? I think all this is public outcry. So what is really important is to have the information out there for communities to demand. And this is what we did with the Stop Stockouts campaign. We trained civil society organizations, but also media houses that independently went and monitored and routinely would have a pill check and then ask communities to report on availability of particular medicines. And when this was presented to policymakers in meetings, but also the media, the newspapers were full of this reporting. So in essence, it was a public outcry that led to the changes that the government did. But also we engaged the private sector both in the surveys, but also I showed you where there was an initiative to get the information and collect it for the public and have flyers that communities would use and engage with the private retailers to demand why, say, they were selling a particular medicines at a particular cost when the average was so much. And so, with such empowerment of the public, the different players are actually forced to get in line. Thank you.
There is another question on the Q&A by Gavin Price. In the USA, hello from New York. We have many pricing transparency issues as well, and a similar opportunity could exist to build a transparency tool. What dashboard-like tools, if any, already exist beyond EURIPID for governments and the public?
Yeah, maybe I can answer it. So I am not aware of currently existing dashboards like EURIPID, and as you say correctly also in the chat, right now EURIPID is only accessible to participating pricing and reimbursement authorities, and sometimes also for researchers. It is hosted by the WHO Collaborating Center for Pricing and Reimbursement in Austria, or it's not hosted there, but they, I think, host the PPRI network. But there are all kinds of initiatives to build a dashboard, but it's something that still lies into the future. It's also interesting to think about what kind of indicators would be relevant to show on such a network. We also know that several countries share parts of the information. So then we would need to gather all the information that is already available and signpost that towards a dashboard. So it's I think also technically an extensive project. But I know that, for example, OECD has published a report where they have selected several indicators that would be relevant for such a dashboard. For example, how many products have market authorization, what is the time between market authorization and reimbursement status. So that kind of information could be visualized in such a dashboard. The Dutch government has a dashboard, but it's very difficult to find. If you're interested, I could share the link to show you how they visualize the time that a medicine takes before it ends up being reimbursed. So that is something that I know of, but it's not broader than only the national context as far as I know. Oh yeah, I share the link.
There is another comment in the chat saying that, just for reference, Tamil Nadu Medical Service Corporation has historically posted its public tender results online, and the prices are always very, very interesting. And that's a thing that has been mentioned, although not directly, on the role of also public procurement and public tenders in transparency. Dennis mentioned it in the framework of the African Union, but this is happening at different levels. Also regionally in Europe, there has been successful cases of public tendering of vaccine in Baltic states that have disclosed net prices within the public tender, but also for biosimilar products. In Spain, we have already 2 strategic agreements on biosimilars that prior were very expensive, where you can also calculate what was actually the net price paid by them, which is considering something generics biosimilars that were probably not covered before. So that's something also to reflect on what we can see in these next joint procurements. Okay, we are a bit past the time, so I'm gonna give the speakers a final round for reflections, and I'm gonna ask them to please provide some intel or insights from their expert opinion on what do they think is the road ahead for advocacy in this field for the EU Transparency Directive and transparency in the EU, but also like how to refresh all these initiatives that Meta has carried along these years, but now that are in decline. How do we take them back, and how do we find political momentum for them to refloat? You can go first, Rian, and then we close with Dennis.
Yeah, so the road ahead is, I think, being aware of what is already out there. Also, maybe force governments to be transparent about the decision that they take, and also make prices available, maybe not net prices, but list prices. Patients should be informed about the access of medicines in their country. And collaboration, I think, is also key between countries. They need more negotiation power or balancing power against the power of big companies, I guess. And we can also learn between different regions. So that's why I also appreciate that me and Dennis are in the same session, as there are a lot of experiences also from the African continent that we, as Europe, for example, can learn from. Yeah, I appreciate that this conversation, and I will also leave a link in the chat if you were not aware yet. There is a web link from the WHO where they have collected all the information that is available for countries on medicines prices, but also other market information sources. So that could also be registration status, etc. So I hope that could be useful to some of the participants here. Thanks.
Thanks, Rian.
Should I go?
Yeah, go ahead, Dennis.
Okay, thank you, Jeremy. Well, for me, the road ahead, really, funding is really important. We can't hide our heads in the sand and hope that this work will continue without funding. There is need for alternative funding for this work. I think it's also asking too much to ask, civil society, who are now, there's almost no funding for the development now, to be required to monitor government work without funding, but also to be able to present shadow reports or something like that to governments without any support. So funding is really important, and I think the development sector we need to look for more funding for this kind of work. Then evidence. It's evidence that created this change. We need to ensure that this evidence is out there, and I think collaborations with academia, I think, will really help moving this forward. But also data systems. We need to ensure that there are more data systems like the MSH price guide, and we must ensure that these are incorporated in all these initiatives that are being set up. For example, the African Pool Procurement Mechanism, there must be data systems with that help with disclosure. If it's with the the platform for harmonized African health products manufacturing, there must be data systems to help. So we must ensure that data is available and accessible to everyone. Thank you.
Thanks a lot, both for Dennis and Rian. We are finishing this session. You will get the recording available and you will be notified automatically by the system if you have registered. So that will be up for you to watch and download, and we will be sending some notes in some weeks, probably after the summit, with a few highlights on this session, and we will be informing soon on the next session that we'll be hosting in September, probably around the OCDE proposed net price sharing platform. So thanks a lot. Thanks for the speakers for their time and willingness to participate, and thanks for the audience to engage with them with such critical questions.
Thank you.
Thank you. Thank you for organizing.
Thank you for joining.
Bye-bye.